Let's start with Richard's observation, quote, "The American healthcare system is going to crash." Agree, disagree, and whatever you think, what do we do about it?
So I think it's really interesting. I've been a student of the healthcare system since my father gave me two different career choices when I was a kid. He said you could either be a doctor or you could be a physician, and so I chose physician because it sounded more sophisticated. But I've been reading articles about the collapse of the U.S. healthcare system since I was 16 years old. That was 1996 for those of you who are counting. And 20 years later, 30 years later, sorry, we're still talking about the broken healthcare system. The real challenge, I think, is it's become a jobs program for the American public. 1 out of 5 jobs in this country right now is a healthcare job. And so when you talk about changing healthcare, you're actually talking about changing the contours of the U.S. economy. And I think it's really challenging. I was at Congress just a couple of weeks ago testifying before the Ways and Means Committee, and you have this incredible sense of the challenge that we have in front of us, which is the challenge that we've always had, which is we want everything to be better and we want everything to be cheaper, but we want nothing to change. And people's jobs depend on it. Politicians' careers depend on it. Everyone wants Medicare to get cheaper, but no one wants to cut benefits. No one wants to increase cost share to older adults. And so I think we're in this incredible collision right now of a lot of different forces, but I candidly don't know what the real tipping point is going to be. And I think it's because we have a leadership crisis. We've had the instruments to make healthcare better for a long time, but no one's making it better. I think there's very few examples around the country of people actually making it better. Instead, it's just feeding itself because that's what we do.
I remember mid-'80s, before you were born, the American healthcare system is unsustainable because it's 11% of our GDP. Yes. And obviously that was wrong because it has been sustained. So if it implodes, if it ever hits that tipping point where the pressure to change it overwhelms the pressure not to change, as you pointed out, a lot of forces of stasis, what would that be? Can you imagine that happening ever?
Yeah, I mean, I think it would require a broader geopolitical collapse, right? I don't think healthcare by itself we're frogs in boiling water, guys. It collapsed long ago, and all of the kind of evidence of that collapse shows up in talks like Richard's and what we experience every single day working in this healthcare system. So it is broken. It's been broken. But the impetus to fix it is going to come from some broader geopolitical collapse. I don't think it's going to be something intrinsic to the healthcare system, candidly.
What could that be? Not that
the debt crisis. I think if we're not able to somehow get control of Medicare spending over the next 7 years, there's the Medicare trust fund has been bankrupt multiple times according to multiple estimates. Right. And we always find a way to turn the knobs a little bit in ways that don't cause too much damage. The broader need is for those knobs to fall off the machine and for us to rebuild the machine is kind of how we have to think about it.
Do you agree with Richard that the thing that might do it is people with good insurance who thought that they were somewhat insulated from the cost all of a sudden realize they're not?
I mean, I don't know. How many of you have a high deductible health plan? Right? I have one. I think we don't really have coverage anymore. I mean, the truth is most people are avoiding care. People in this room are avoiding care right now because of the nature of their coverage. They probably need some test and they don't want to go because they're worried about a surprise bill.
I'm obviously avoiding Ozempic.
Yes, we both are. We both are. So I mean, I think that the reality is that it is all broken beyond repair. We're all somewhat complicit in it, and we have to kind of think differently about what we do going forward.
So let's get a little to you. Tell us about what your current job is, what SCAN is, and where you live in the overall ecosystem.
So it is not a radiology company. When people see, yes, it is a good name for a radiology company. It's a terrible name for a healthcare company. It was actually founded by a group of people we call the 12 Angry Seniors. And SCAN is essentially what happens when 12 seniors get really pissed off about the state of healthcare and get together in a garage somewhere and say that they're going to try to fix it. We were founded as the Senior Care Action Network. And we have been really focused since our founding in 1977 on actually trying to improve care for seniors. And I would say we're still at it because obviously it's not fixed yet, but we're here to try to make senior care
So what
better.
is that? I can imagine that meant something before Medicare Advantage and means something different after Medicare Advantage.
It's interesting. What is old is new, and what is new is old. So a lot of it was social determinants of health. So in the early days, they were setting up rides for seniors to get to medical office appointments. They had food delivery to seniors who needed it. They provide friendly visitor programs for people who were lonely. So that was the stuff that was happening.
Under
in the
what
70s.
Financial model? Like who
This was
would pay for that and why?
It was community service originally, and then they eventually became part of the social HMO demonstration project that HICFA ran, which was, again, the first instantiation of social determinants of health and Medicare financing together. And then when HICFA retired that and launched Medicare Advantage plans, we transitioned over to that. So we have about 310,000 MA beneficiaries in California, Arizona, Nevada, New Mexico, and Texas now. We also operate 4 different medical groups that are focused on special populations.
So Medicare Advantage was supposed to be the great savior.
It was.
It was, meaning it did, or it was supposed to be?
No. It's the program is in many ways like corrupted. It's like a really good computer program that has a virus in it right now.
Is or was it a good idea?
I think it was an amazing idea, right? So just the basic idea was take Medicare, which had a cost profile associated with it, and try to integrate benefits and manage care more closely and try to reduce costs. And anybody who's run a healthcare P&L knows most of the costs exist in hospital admissions. So if you're trying to actually manage care better, you're trying to keep patients out of the hospital. The ways you do that are intensive primary care, chronic disease management, focusing on the social determinants of health. The original idea was amazing, and then there were a lot of distortions. So the first thing is that in the original instantiation of Medicare Advantage, there was no risk adjustment. And so it meant that lots of people set up their brokerages, and this actually happened, I've now validated it, on the second floors of buildings to avoid sick people. So if you had an MA plan, you would set up an office on the second floor, and the person who's handicapped or had mobility issues didn't climb up, and so you got positive risk by actually getting a bunch of healthy people who wanted gym memberships. And that was the kind of stereotype of what happened with MA in its early days.
And it actually did happen.
And it did happen. I've now talked to people who set up those broker offices on the second floors. And then eventually CMS said, this is not good, and we actually want to create incentives for sick people to be managed better. And so they set up the risk adjustment program, the famous HCC coding. And the goal was to incent plans to actually take care of sick people and manage their costs better. And then, the provider world and the plan world realized, if I just code some of these people, and I find some of these really interesting codes that actually are not really associated with a lot of cost, I can make money on the arbitrage. And so MA became really big business for both managed care and health systems that knew how to work within it, posting 5, 7, 8, 10, 12% margins depending on where you were and how well you played the game. And honestly corrupted the whole system. And it's one of the reasons why I moved away from kind of the for-profit world in MA to the not-for-profit world, because it gives us a bit more flexibility to do it the right way. But we also have to work with the world out there, which is oftentimes not doing it the right way.
So you were in government. I guess it's interesting as you describe what happened to this good idea, whether it's the offices on the second floor or in some ways corruption of risk coding. It all seems pretty predictable in retrospect. It's like in a system where people are trying to figure out how to make a buck. It seems like how's that not going to happen? If you're in government and you're planning MA or the next iteration of MA, how do you miss that?
So here's the fascinating part of the story, and I was fortunate to actually be there during this period. So the ACA happened, and there was some improvement of the risk adjustment model, and everyone kind of thought MA was fixed. And they also, this is the more important point, thought that MA was a big nothing burger. So our friend Don Berwick, who was CMS administrator, kind of treated MA like it was just this side program over there. 2010, 25% of MA beneficiaries, Medicare beneficiaries got their Medicare through MA. So no one was really talking about MA. CMMI had no interest in doing anything in MA. There were no MA demos. It wasn't on the agenda. No one was talking about it. Fast forward 14 years, MA is now the majority program for Medicare beneficiaries, and it's a huge part of the social safety net for low-income and middle-income older adults. And now you can't take it away.
It's too big to fail.
It's too big. It's failing.
It's too big.
Right. It's too big. It's really big. And
yeah.
the truth is it really went away from its initial intent, which I still think is pure and golden in a lot of ways, which was let's create the capacity for the delivery system to actually manage risk under a global budget. You know, if appropriately risk adjusted, you could actually keep people healthier. And you see it work in pockets, but then you also see a lot of organizations that have corrupted the system. And you know, they oftentimes, those same systems and those same entrepreneurs and companies are sitting on stages like this, and they're bragging about 55% MLRs and 56% MLRs.
What's MLR mean?
Medical loss ratio. And so they're talking about, you know, how great a job they're doing medical cost management. And what they're not really telling you is that they're really just doing medical revenue management, which is the denominator is really big and the costs are the same as they've always been. And the work should be to actually reduce the true absolute costs, not the costs relative to a premium dollar number, which has gotten inflated over time.
So I guess that's the question. Did it work, even though it's corrupted and people are doing games, did it work in terms of lowering the overall cost of care?
No, I mean, but I think it could have worked, and I think it still can work. But I think that the regulatory oversight of the program really, and the infrastructure needs to really move in the direction of really creating incentives around care management. But I believe that actually, like seeing a person on an outpatient basis who has a higher degree of morbidity more often, and providing them with the time in the system to actually take care of them, can obviate the need for hospital admissions that otherwise bankrupt the system. And the challenge is that the systems have a lot of ambivalence about this. If I went to the CFO of UCSF today and said, I'm going to reduce your hospital admissions by 20%, he would fire you or find a way to fire you, or
he's already working on that.
So, you know, and there's a lot of stories like this, you know, all across American healthcare. And so I think the challenge is that, and this is where I really go back to the leadership crisis point, if we're all in this to keep people healthier, why aren't we using the tools and business models that we now have available to us to do that in an ethical way to actually do that? It's because it's just way easier to hide behind no margin, no mission. Mm-hmm. And that's another corrupted phrase in American healthcare, I think, because we've stopped even asking what the basic mission is. We're actually just kind of focused on kind of producing margin without any real view to what that margin is earned on, which in my view is oftentimes taking care of people who could have been cared for better under a different model, and being rewarded for it.
So I know how socially conscious you are, and it's real. And yet you're in this system now. You said I'm not on the for-profit side, I'm not for. So what do you do differently than all of your peers?
Yeah, I mean, look, you can't fix it from the outside. I could throw bombs, I could write papers. I tried doing that. It didn't really work all that well. Mm-hmm. I still remember the first paper I wrote, I kind of sat by my inbox hitting refresh, and I was like, when are people going to tell me what they think about this thing? Nobody reads anything, is what you learn. You're an author, you know that. So I decided I wanted to kind of get my hands dirty and throw myself into the game. And the thing that we do, I think that's different, is we delegate as much of the revenue to the delivery system as we can. So we target a 1% margin on our side, and then we give the rest to our risk-bearing medical groups and say, go manage it. The other thing we do is we try to operate with a higher degree of transparency than the big national for-profits do. So they'll sign a deal with you, but it's one of 25 contracts that you've got. You're not really reviewing the language all that closely. And then 5 years later, you're into this deal and you're looking at it, and they've deducted all kinds of costs from what they're paying you, and ultimately you're not making what you should be making on these deals. And so we try to be a lot more transparent, a lot more provider friendly, and I think in the process have grown a lot over the last couple of years.
So what value do you bring? Because it sounds like you take a bunch of money and you hand it to one of these folks and say, you are the medical group and you own the risk. So why don't they directly contract with Medicare to do that?
Yeah, so it's product design. The truth is that we could be put out of business and I would be okay with that. I mean, but the reality is many health systems have been in the health plan game, and they don't do very well at it because it's a completely different business. Most provider-sponsored health plans are struggling. They're subscale. There's medical cost management issues. And so again, I think we could be easily out of business. Our view is we should be the intermediary that supports plans and actually taking risk. But to your point, distribution, product design could be commoditized in a world enabled by AI. What do we need anybody for?
Well, that's a different question. Yeah. So yeah, talk a little about technology in both in your business, but also more broadly as you listen to Richard, and I'll talk a little bit about it. Sort of where do you think tech and AI fit into all of this?
So we've made pretty significant investments in AI over the last couple of years, and candidly have really struggled. We have incredible capabilities that have been deployed within our company that people aren't using. And they're nice things for us to tell our board. Oh, we've got an AI call center monitoring capability that allows us to literally build a word cloud of everything that's being discussed all the time, in our call centers. And so we can know if there's an issue with our OTC benefit or if there's a provider group that has access challenges. The problem is people aren't looking at it. Why not? People aren't using it because they've done their jobs the same way for 20, 25 years. And so all of a sudden you give them these new capabilities and these new tools and they're shy. They're AI shy. They're not necessarily interested in using those tools to actually change how they do their work. Most of them have retirement on the horizon. So they're kind of pushing this thing out as far as they can. They use a lot of charged language about hallucinations. And so people are really, really shy. I mean, we're projecting a really big growth season this year. And my call center operator 2 months ago said, I need 160 new bodies. And I said, can't we find a way for AI to better support us? And they said, well, I just want to make sure we can handle what's incoming right now and we can deal with the AI stuff later. As opposed to potentially use, and I sympathize with that perspective. I think it was a reasonable, conservative, good perspective. At the same time, you could imagine a world in which somebody with a little bit more experience with the technology would say, okay, we're going to create 3 different queues and we're going to use AI on these types of requests and we're going to use humans for these other kinds of requests, and in the process, actually reduce the total headcount that we need and probably even shrink our call center. That is the work that's going to happen over the next couple of years. But I would tell you, most people are very AI shy, sure. And are using it in ways that are, they're implementing it, but they're not necessarily transforming.
But is that a leadership challenge for you to say, I've heard all that stuff, but it's time? I mean, we can't afford.
It is, and the truth is that
more FTEs.
Yeah, and the way we would do this if I was at a for-profit company is I would say, well, we have an EPS target to hit, and let's just go after it. And in a not-for-profit, you don't have that EPS target to hit, and you have boards that are a little bit more permissive and more comfortable with writing it out the way it is. And so, to your point, Bob, I just told my team that we're going to go after $30 million in cost savings. We're just going to invest it back in our mission, of course, but we're going to go after it. And that kind of scares people a little bit. Of course. So, and that I think may force some of the action.
In 1949, the great physicist Max Planck, who wrote I think his autobiography, and he wrote something like, a scientific truth does not emerge from people learning it and changing their ways. It emerges as a generation dies off and a new generation takes their place. So that's sort of an aggressive form of HR.
But I will tell you, to cite another great thinker in this world, John McEnroe. I was fortunate to attend a talk with him and actually hit a few tennis balls with him. And
did you beat him?
That's a secret between me and John.
Okay.
But he essentially said he runs this tennis academy in New York that some of you probably send your kids to, and he said he can't actually get his instructors to teach with the methods that he's actually advocating for. He's a big serve and volley guy, and he's not able to get. That's an older way of thinking about playing tennis. And he's not able to get his instructors. It made me feel so much better about not being able to get anybody who works for me to do any of the things I asked them to do. Hopefully it makes you feel better too. It's very.
Well, his people probably don't scream the way he does.
Yeah, exactly. Yeah, exactly. So I think that is one of our biggest challenges is actually how do we get healthcare organizations to operate more, to move in the right directions. There's too much consensus-based leadership decision making. There's too many committees, huge governance problems. Everyone feels like they run everything and no one runs anything. And as a result, it's really, really hard to make progress in healthcare organizations. I think our biggest challenge is maybe the organizational behavior problem in healthcare, which is we all work in highly dysfunctional organizations. There is a degree of dysfunction that we've normalized that doesn't exist when you kind of go into other sectors. That I think...
Is that true? I mean, you have an MBA and you've thought a lot and seen other sectors, and sometimes I think we romanticize how well other sectors work. You really think there's fundamental differences?
I do think that so I'm somebody who can kind of play both sides of this argument, and I often do. But I will tell you, the idea that, everything requires 27 committees to get done. Yeah. The idea that we're, kind of completely stagnant all the time is a distinctly healthcare view of the universe.
And you're a CEO, so you theoretically could change the leadership.
Yeah, and I'm experienced probably as abrasive, and because I actually want to try to challenge the organization to do things. And I think
the culture is so embedded. It's just
it's taken. It's interesting. So I inherited this organization 5 years ago as a regional not-for-profit plan. And I always tell people that there were two companies that were founded in 1977. One of them was Scan, 5.5 billion in revenue, 2,500 employees, 310,000 members, and the other is United Health Group. But there's something about leadership, ambition, drive that takes organizations to one place versus another place. And we don't talk enough about the importance of leadership, and bigger is not always better. So I'll say that. There's a lot of kind of manifest destiny in healthcare to make things as big as they possibly can be. And I think we've lost the soul of most healthcare organizations by becoming as big as we have and by making people feel as invisible as we have made them feel. At the same time, there is, I think, there is a need to try to actually make things better and work.
Have you come up, when people say, give me one or two things I should do tomorrow as a leader that I'm not doing?
So there's a lot of people who say inspect what you expect, right? That's one of these common health, leadership truisms that everybody, but there's this next step to it, which is, and then take action on what you inspect, right? So everyone's inspecting, everyone's talking about the problem, everyone's admiring the problem. But the next step is the actual taking action on what we inspect and what we see. And I see that is very rare. We hold people accountable oftentimes for the wrong things. And you and I were talking about this yesterday, that there's been a lot in the last 5 years where we hold people accountable if they say the right thing the wrong way, then they're out. That's been, I think, part of also the toxicity in healthcare cultures over the last 5 years. But I think that the opportunity is to now really hold people accountable for did you do your job? Did you move the needle? Did you actually change the outcome? And the highly political nature of large enterprise across all industries means that we oftentimes prioritize the survivors and the sweet talkers and the corporate politician over the person who actually gets things done. And I think that there needs to be a reckoning and a reset of organizational cultures where we really do honor the person who speaks up about the right things, where we do honor I often tell my teams, I'm that crazy person who says the right thing in the wrong way, your job is to support that person, right? As soon as they say the crazy thing, be that's a good point, so that the rest of the room actually honors what I call courageous, what we call in our company, courageous challenge. But most healthcare organizations have gotten really, a little bit 1984-ish, where if you are that person who does speak up a little bit, it's you're out the door. So we need to honor the crazy a little bit more.
Pivot to a couple other topics. You mentioned that when risk adjustment became a thing, there was a whole industry around how to game that. In some ways, it's part and parcel of a broader challenge of measurement. That the quality movement began and the safety movement began around 2000, and we're going to fix these things. And the next step was, we have to measure it. Because then we can build incentives or transparency. And I think most people feel like that's been a failure, that the measures haven't worked very well, they don't actually capture what you care about. So what's your thought about that?
Yeah, so in the year 2000, I applied for the Truman Scholarship. It would have paid for 2 years of medical school. And I didn't get it. And my entire proposal, whoever read it was pretty smart. My entire proposal was building more healthcare measurement. And they just didn't like the proposal. And I think, the truth is who wants more measures? Who wants more grades? Like, anybody want more measures? Michael Porter maybe wants more measures. Elizabeth Teisberg wants more measures. Don Berwick for a while wanted more measures. And then we turned it into an industry. We have literally a measurement industrial complex, companies that actually profit, nonprofits that actually profit from actually creating more measures. Some of them are written into statute and written into law and we measure health plans with measures that are now required by certain purchasers. I mean, we've kind of created this web of the measurement industrial complex. And I just would challenge anyone to show me like measures that actually really change care in good ways. We talk a lot about the Crossing the Chasm report and all the great work that the IOM did to define the problem, a couple of decades ago. But who thinks healthcare's gotten better in the last 2 decades? Find me anybody who thinks healthcare's gotten better. So I think the challenge for us is to find ways to improve where we measure the right things, a simpler set of things that actually matter to people. Mm-hmm. And I think most of the things that we measure have created a self-perpetuating system that haven't necessarily made anything better.
Yeah, it feels like a version of this second floor office thing. It seems like, and I was part of it, I was in groups creating measures, and it felt like we were doing God's work, and then you realize this is just making the bureaucratic burden that much harder. But when you're there in the moment, I think it gets corrupted later, but it sort of feels like you're doing the right thing. Like, this is the best measure I can come up with for patient safety or for quality or for a risk adjustment, whatever.
Yeah, I mean, look, we're subject to the star rating system, and Medicare plans are rated on the 0 to 5 scale. And we've always prided ourselves on a 4.5-star rating. We're the best, longest, best rated plan, and I can tell you why that's really important and all this stuff. And then one year we grew a lot, and because we grew a lot, your measures, your star ratings usually go backwards because you have new members, it dilutes the scores. And we projected that we were gonna go from 4.5-star measure to 4. And so we told our board we were gonna go to 4. And then we got our star rating, and we had declined to 3.5. So then we started to look at what actually happened. And we had projected a 3.77, and there was one French foreign language phone call. This is a true story. So we have no French members. We have like 8 French members at all of Scan Health Plan. But CMS uses these secret shoppers to test whether you can actually respond to a foreign language caller in a timely way. So we got one French foreign language phone call that was rated as a fail. And then I went and listened to the call, and the questioner asked the question in a really weird way and kind of like ran the clock down a little bit. And so we were 36 seconds over. And so we went ahead and we appealed this to CMS. And you'd say, why do you care so much? It's not just about, there was $250 million of revenue tied to this, to the 4 to 3.
Going from 4 to 3.5. $250 million.
And most of that revenue would go to our provider groups because of the way our contracts are written. And also it gets invested back into benefits. So if you have a higher star rating, you can actually field more benefits. And so this was about our members, and this was about our provider partners. And so we went to CMS and we went to the examiner, and the examiner is like, no, this is perfect, the way we did this. And then we went to the head of the Medicare Advantage program, and she said, the examiner says it's perfect, so therefore it's perfect. Then we went to John Blum, who was the deputy administrator. And then we went to Mina Shesamani, who ran the Medicare program. Then we went to Secretary Bashara's office, and he was like, yeah, there's really nothing we can do about this. So we actually sued CMS in a federal court, and we won. We won on kind of 2 different kind of counts. One was the French phone call. The other was that they implemented this new Tukey outlier methodology that moved the cut points. And our star rating, once they restored this one measure, went from 3.74 to 3.83. And so it rounds up to 4, and they recalculated it for the whole industry. And all of this is to say, we were not a better health plan because we had this one French phone call. We weren't a better health plan or a worse health plan because of this French foreign language phone call. And so even though I brag about my 4.5-star rating, I'm having a very honest conversation with all of you today. It's great that we're a 4.5-star plan. We subsequently regained our 4.5 stars. The point is we have these differences these distinctions that don't actually really represent any real difference. And I think that's, just drive down any highway in America and look at all the top-rated health systems, or probably all your health systems and medical groups. Everybody's top-rated on some measurement. And so the whole thing doesn't mean anything anymore. And I just think we have to kind of really take a look at that and ask ourselves, and then the fact that it's tied to payment and it's tied to benefits and it's tied to revenue for medical groups, it's kind of gotten completely insane. So I didn't answer your question, but I really wanted to tell that story. I really wanted to tell that story.
I thought the French story was pretty cool, though. But you need something, right? You need something that drives the system in the right direction. You need, therefore, some measurement of your performance for either transparency or consumerism or.
But here's the interesting thing about it. So the consumerism part, I'll tell you, we're 4.5 star. We've been 4.5 star 7 of the last 8 years. There are 2.5 star plans that are growing better than us. How come? Because of no one pays attention to these ratings, actually. And most decision making around plan choice is made by brokers. And brokers have different relationships with different plans. And so, if I grease the right people in the system who don't necessarily care about ratings, people will still come. I mean, you can be in a competitive hospital market where there's really good hospitals and not bad. People still go to the not great hospitals. So the truth is that I think that we overestimate the consumerism health.
So when you're thinking about those stars, it really is not some kind of marketing.
For us, it's about revenue.
It's just revenue.
It's revenue. It's the ability to feel good benefits. Yeah. But I don't think people are making a lot of choice based on ratings.
You'd mentioned when we spoke earlier that you know Dr. Oz, and if he called you this afternoon and said, "Tell me the 3 things I should be doing," what would you tell him?
So number 1, multi-year enrollment. So one of the questions on your page that I was excited to answer that I didn't get a chance to answer.
Go ahead and
answer.
I'm
going to do it and answer is we've been living in this value-based care delusion for a long time. And I worked for Michael Porter when he kind of popularized that phrase and sold a lot of books, getting people thinking about value-based care. But the one thing that nobody talks about is you can't do value-based care in 1-year increments. You just can't. I mean, you basically enroll someone, you get them in for a primary care visit, and then they're deciding if they want to stay with your plan the next year. And it's one of the reasons that digital health has never really kind of had the life that it's had, because it should have, because the investment that it requires in year 1, year 2, year 3 to really get somebody the remote patient monitoring, to do the home visits, to do the chronic disease management. You're not going to do those things if I don't know if you're going to be my member next year. Mm-hmm. So we've decided in this country that 365 days, in the world, that 365 days is somehow magical. Go across the pond to Israel, where you're born into an HMO. You can switch if you want to. But they're taking a whole life view of you. And so they are doing things like in years 20, when you're pre-diabetic, they're leaning in really hard to make sure that you don't progress from pre-diabetes to diabetes, because it's the right thing for you and because it's the right thing for their P&L long term. We don't have any of that kind of thinking here because so you have a hemoglobin A1C of 5.9. Who cares?
Right.
What
it's going to play itself out over 20 years.
Yeah, exactly. Right. Who really cares? So you're not on metformin, you're not getting a DPP. So again, I think we have to increase the time horizon. That's number 1. Number 2, this is a really hidden part of the healthcare system.
How would you do that? You would just say you're making a health insurance decision that is a 3-year decision. There's no re-enrollment.
Yeah, it's a 3-year decision or a 4-year decision, or if you have to take the pragmatic reality that some people don't want to do a 3-year or 4-year decision. I can take a lot of sales and marketing costs out of a plan, and I can reinvest that stuff in benefits. So give people the option of enrolling in a 1, 2, or a 3 or 4-year plan, and give them richer benefits if they're so do it by a strategy of attraction as opposed to regulation. So I think that's certainly an option. So that would be policy proposal number 1. Policy proposal number 2. We have all these workforce shortages in U.S. healthcare, but I think we actually don't, is my view of it. I think we have workforce misallocation, and there's a hidden workforce that has been misallocated, which is the insurance brokers. So, whatever you think about an insurance broker, they are better at behavior change than most of us are as doctors. Because if someone is able to convince someone to join an insurance plan, they are really good at changing behavior. And I think that most of us don't know is that brokers are paid for the first-year enrollment, and then they're paid every year thereafter for the enrollment. So there's an annuity built into the Medicare Advantage program from a broker perspective. Anyone want to fathom a guess of what we pay brokers for a first-year enrollment in Medicare Advantage in California? Anyone? Throw out a number. Huh? It's about $880. Yeah, so good guess. But then that's fine. But then you get the tail commission for the rest of the person's life. Anyone want to guess what that is? $250 a year. It's $440. So it's 50%. So we pay more for a Medicare Advantage enrollment right now than we do for neurosurgery, on a lifetime adjusted basis. So I would suggest that you either find a way to take that money out. They're way more politically savvy and active in Washington than anyone. But rather, I think you should have those folks engaged with those members for the rest of their lives. So if you're going to get $440 for the rest of their lives, you've got to do something for it. You got to make sure people get a primary care appointment. You got to make sure that they're actually getting their refills. All the stuff that right now is finding its way into doctors' offices, put it to the brokers. Make them earn that money. Because $440 is more than we pay a primary care doctor for a primary care visit. Mm-hmm. It's more than we pay for 4 months of capitation in California for primary care. So I just think that you have a huge opportunity right now to take money that's already in the system and completely reallocate it to something different. That's another thing. And that's doable. I mean, that's actually these are things he could actually do. And then the third thing I would tell him to do is blow up the whole star rating system. There's too much quality, and relook at all of quality measurement for all of healthcare right now, and try to just simplify the administrative infrastructure. We can put as many slides as we want up about the administrative bloat, but it all comes from something. It comes from unfunded mandates that are kind of put into the system. And I think we just have to kind of start one by one, kind of like crossing out the unfunded mandates in healthcare.
I think that's a great place to stop, and very inspiring. Thank you, Sachin. Really appreciate it.